Hello, uh, very good evening to all my fellow colleagues, the faculty, and all the delegates who are logged in right now. In this platform of focus studies in breast cancer, which has been basically running on a webinar only, online only mode from the time of COVID, it's now been, I think, 6 years, and it's been a pretty successful 6 years, I must say. And now that Dr. Geeta is also here, I must say somewhere we were sort of
Recording stopped.
attracted to this concept of doing webinars by seeing Dr. Geeta and some other colleagues doing this, and we thought we will also explore it. And the response was so good that we have continued with this process, and I believe this is something which really works very well for the faculty as well as for the delegates. So for nearly about last 9-10 months, we have started this series of a master class in breast oncology. And previously, we were focusing on pathology, imaging, and all. And now we have come to the treatment part. Basically, the first session, this is on the management of the breast primary. And overall, we have, I think, some of the best faculty who can be there to speak on this issue. We have Seenu, Geeta, Vedant, and Dilip Vaisa. And I believe the senior faculty who's there, they are going to give you a concept of how the field of breast surgery has evolved, what is the philosophy. Understanding the history, the philosophy is probably very critical to really coming to grips with the field. And without taking much more time, I'll now hand over to my colleagues, Dr. Vaishali and Dr. Prekshi, to take it further.
Thank you, sir. A very good evening to all of you. So, as sir also said that today we'll be talking about breast cancer surgeries. Breast surgeries has evolved. They have evolved from radical surgeries to individualized, less invasive approaches. So, in the first talk, we'll be talking about the current scenario of breast cancer surgeries. And to do the favors, we have with us Veenu sir, who is Director, Breast and Endocrine Surgery, Medanta, Gurgaon. Over to you, Noida. Sorry. Over to you, sir.
Yeah. Thank you. Thank you, Dr. Prekshi. And thanks, Arun and Vaishali, for carrying on the baton of academics. Being in private sector and showing so much interest is really astounding. And we feel very proud to be associated with focus studies in breast cancer. So basically, we always feel that we are wise, especially in hindsight, because we always think that our brains connect the dots of past events much easier than we can predict the future. Once an event happens, our brains quickly put a nice, neat, logical story.
Recording in progress.
Convince us that the outcome was all along known, something which can be called as I knew it all along effect. So same is true of breast cancer. Like you may look back and say sometimes as to why it was done at that time that way. But thing is the amount of evidence which is available and the way things went at that time. So that's how it was done that way. And whatever was done stood the test of time for more than few decades. So here I am to talk about the evolution and changing philosophy of breast cancer surgery. I'll briefly touch upon from the time of Halsted to Fisher to the current biologically driven precision surgery. Now, if you look at the breast cancer management or the breast cancer understanding, it is an evidence which is more than 1 century old. Initially, we had the anatomic era, which was basically led by Halsted. And then came the Fisher's biological era, where it was realized that a tumor, once it is of a certain size, it acquires blood supply and can metastasize bypassing the lymph nodes. And from there, from the 1990s, we have come down more to something called as a precision or biologically driven management of patients based on the tumor and the genomic biology and the individual genetics, which determine the therapy and dictate the extent of surgery. So when you look at Halsted, like this is the statement Halsted had made in one of the conferences at that time. I cannot emphasize too strongly the fact that internal metastasis occurs very early in cancer of the breast. And this is an additional reason for not losing even a day in discussing the propriety of an operation. So Halsted also did understand that the breast cancer spreads very quickly beyond the breast, and the best way to sort it out is to sort it out loco-regionally. And so what did the Halsted concept tell us actually? It said that the breast cancer spreads in an orderly, predictable, centrifugal fashion. So this is true of most of the solid cancers, whether it is a head and neck cancer, whether it is a colorectal cancer, whether it is a pancreatic cancer. The understanding has always been that there is a orderly and predictable and centrifugal fashion of spread. And that is also the basis of our sentinel node concept. So what was understood was what we studied in classic Robbins textbook of pathology. Initially, there will be local invasion of the contiguous tissues, here the breast tissue. Then there will be orderly lymphatic spread to the lymph nodes, which trap the cells, which stop it. And only when it becomes over and above the capability of a lymph node to stop it, does it cause a hematogenous or a distant spread. So in this type of understanding, it was felt that the hematogenous or the distant spread occurs much later. And this was very well accepted, and therefore en bloc radical mastectomy was considered as curative. And for unbelievable 80 years, the unchallenged standard of breast cancer treatment was loco-regional treatment. And this was because the results which were coming were reasonably acceptable compared to what they were facing before. So it was felt that they were going in the right direction. And can anybody tell about this? Actually, this is a webinar, I can't tell. This is one of the models who had a breast cancer. And this came on the New York Times magazine on the front page, was also nominated for the Pulitzer Prize for the best photography. And the caption was that beauty can be there even out of damage. And this is the model, Joanne Matshuka. And the title of this picture, which was nominated for Pulitzer Prize, was Beauty Out of Damage. So even a common person took it that for breast cancer, loco-regional treatment and aggressive loco-regional treatment does give cure. However, as time passed, then you start looking at it. As I said, that the hindsight makes you wise. So what was found was that the radicality did improve the local control, but it did not improve the survival. So by the 70s, a paradox was apparent across the entire surgical case series, whether it was from US or Europe or any other country. If you do a more radical surgery, in fact, we were taught when we were undergraduates as something called as a super radical mastectomy also. So it was found that this does not cause a proportional gain in overall survival, especially in node positive patients. And this was associated, the more aggressive surgery was associated with significant comorbidities like lymphedema, chest wall deformity, restricted shoulder motion. So people realized that there is a gap between the surgical dogma which was being practiced at time and the clinical outcome. And this is what exactly prompted Bernard Fisher to question the underlying biological hypothesis of the Halsted model. He did not question the technique, but he questioned the model of understanding of the breast cancer. So what did Fisher's hypothesis say? Fisher also said that, again, very carefully, most, if not all, patients with breast cancer have disseminated disease by the time a clinical diagnosis is established. So what we understand today is that A tumor, once it is of 1 centimeter, it develops its own blood supply and can go anywhere else in the body. So he said that that is why breast cancer is a systemic disease at presentation and local therapies have no influence on survival. On this hypothesis, Fisher started working, and this is it. Breast cancer is a systemic disease from time of diagnosis. Tumor dissemination is governed by tumor host biology, not by anatomic consequence. And he formulated this based on laboratory studies of metastatic biology, which he published way back in the 50s and the 70s. And he said that lymph nodes are indicators of a metastatic propensity, which is what is currently understood. Lymph node is the best prognostic indicator. However, it is not a barrier that stops spread. If micrometastatic disease already present systemically, more extensive local surgery cannot improve survival. And therapeutic effort hence should shift towards systemic treatment, which is adjuvant treatment, and minimize the morbid local therapy. So this paper was published multiple times, initially with a 5-year follow-up, then 10-year follow-up, and the latest is a 25 years follow-up. And this is the longest surgical oncology randomized control trial of its era. And the key results of this was that there is no significant difference in disease-free survival, relapse-free survival, distant-free survival, or overall survival between radical mastectomy and leg extension surgery, regardless of the nodal status. So this has a tremendous practical impact in terms of the extent of the local surgery, which was initially a radical mastectomy, and it was proven beyond doubt that the extent of local surgery does not govern survival. And this is the first definitive proof of the biological hypothesis as far as the breast cancer is concerned. Now, these two studies tell us about why doing less is adequate. One is the NSAPP06, which is a 20-year follow-up. As I said, more than 2,000 patients, comparison between mastectomy, lumpectomy plus RT. No difference in survival across overall 3 arms. But however, local recurrence rate was more only if lumpectomy was offered. At the same time, Varanasi has been working really hard in the field of breast cancer. He almost worked in advance of what was happening in the US in Milan. He published again a 20-year follow-up. Initial study was for 5 years follow-up. 700 odd patients from a single center, tumor less than 2 centimeters. And he used to do something called as a quadrantectomy. In fact, that was the first breast conservation surgery. We divide the breast into 4 quadrants, and in whichever quadrant, the entire quadrant was removed. Of course, the cosmesis was not very great. However, he showed equivalent survival between mastectomy and quadrantectomy. And he established that breast conservation surgery is oncologically safe. Together with B04, these trials established that breast conservation therapy is equivalent to mastectomy. And this put an end to the Halstedian era. Now, coming to the axilla, like this is a little more recent as far as we are concerned, but again, it is almost about 30 years now, ever since the first paper was published by Giuliano way back in 1992. And this is a 30 years of the different thing is you have more of randomized evidence here, which shows that in some patients, there is no need to do very extensive axillary surgery. Now, these are the 3 greats to whom we have to acknowledge and give credit about sentinel node biopsy. Don Morton, he was at John Wayne Cancer Institute with Armando Giuliano. And Morton was a big name in melanomas. And John Wayne, like the Sydney Melanoma Center, was a referral center for melanomas of entire US. So Morton used to get melanomas around the umbilicus. And you know that umbilicus is a watershed line. Any tumor at umbilicus can go either into right groin, right or the left axilla. So he did have some cases where he had to do 4 sites prophylactic dissection with considerable morbidity. So Morton thought that why shouldn't I look at where the lymphatics go from this tumor? And that's how he initially injected charcoal, tried to follow it. Then he did rat studies with various dyes, including methylene blue and patent blue violet. And he found that the patent blue violet is best to identify the nodes. And that's how the sentinel node concept came. And Giuliano, working at the same institution, applied it to the breast and published his first paper way back in 1992 on the feasibility of sentinel lymph node biopsy in breast cancer. At the same time, like Veronesi again published a beautiful paper in Lancet. Veronesi and Giuliano are very good friends, but they consider each other as sort of rivals as far as developments in breast cancer go. So this is the concept for the youngsters. Wherever there is a solid tumor, it drains to first drain in the regional nodal basin. This you can identify either by injecting a blue dye or by a radiotracer or a combination of both. So from this came the complete dissection to selective surgery. Initially in the N0, NSABP32 showed sentinel node as less morbidity. And same time, Veronesi published the paper in Lancet. Then Giuliano went ahead and told that in minimal sentinel axillary nodal involvement, only sentinel node will suffice. And this was followed by a study from Denmark, the Ameros trial, which showed that the morbidity is less if you give radiotherapy instead of doing axillary clearance in patients with minimal nodal positivity. So the trajectory for sentinel axillary lymph node dissection came from ALND for all to sentinel node as a standard staging standard to omission of complete ALND in selected patients of sentinel node positive group. Now, can the axilla be left alone entirely? Again, this is one step ahead. I find it very surprising. Surgeons have this peculiar habit of kicking themselves out of treatment of breast cancer. So I think in the future, surgery will become an adjuvant treatment and medical oncology will become the definitive treatment. And fortunately, like probably I will not be practicing breast surgery at that time. So this is the sound trial, which again showed that small tumors, negative axilla on ultrasound, sentinel node versus no axillary surgery. No axillary surgery was non-inferior, suggesting that in selective group of patients, you can avoid doing anything in the axilla alone. Similar study, again, the NSEMA study also showed a similar thing with much less arm and breast morbidity. This is another important thing. Initially, we used to go ahead and take as much of margin as positive, but later on it came that no tumor on ink is the standard nowadays. But at surgery, to achieve no tumor on the ink, we have to put our fingers on the tumor, and we have to take a 1 centimeter margin from there to get actually no tumor on the ink margin. And for DCIS, it is 2 millimeter margin. And this again, I think in the latest TNM, there is a modification of even this 2 mm margin. So impact of standardized margins has been that less unnecessary re-excisions, improved cosmetic outcome, decreased healthcare cost, and with no increase in ipsilateral breast tumor recurrence. So evidence rolling back the instinct as to take more margin to be safe is no longer to be believed. Now, letting the molecular biology decide the systemic therapy. This is the Taylor-X style and MindAct style. Taylor-X used the Oncotype DX, MindAct used the MammaPrint. Both of them showed that if this is applied and you find that the risk is less using one of these, then majority of the patients can avoid chemotherapy and you can de-escalate the systemic treatment with no survival compromise. So we are now in the era of biology-driven present and future. And as far as we are concerned, it is oncoplastic techniques and neoadjuvant response and genotype now shape or eliminate the operation. Oncoplastic breast surgery, we have seen that with the use of small rotation or transposition flaps, which you just need to have some basic understanding of the principles of plastic surgery to use majority of these flaps. Majority of them are basically the random pattern flaps. These can be safely used to provide increase the scope of breast conservation surgery and provide comparable margin positivity with much local recurrence rate, and better cosmesis. Same is true with the nipple sparing mastectomy. It has been found that we can do nipple sparing mastectomy in select group of patients and give patients much better cosmesis. Thus, anatomical radicality is not required when tumor biology and location are favorable. Now, another important thing is that, like in patients who have good response to therapy, probably the therapy can replace surgery. 96% of patients with confirmed PCR after neoadjuvant chemotherapy also have axillary pathological complete response. So in such patients, it may be possible to do sentinel lymph node biopsy. And there are now studies ongoing to see whether avoiding surgery and giving only RT to these patients will suffice. The philosophical mirror image of Halsted is what we are seeing today. Real time biological readout, not anatomical instinct, determines whether surgery is needed at all or not. Now, this is what we are currently practicing. A lot of us in the corporate, majority of the patients in the US, like you do surgery before even the cancer comes. That is, in patients who have high risk of developing cancer, you detect them by doing the BRCA1 and BRCA2. And if they are positive, if you do risk-reducing surgery, then there is a 90% reduction in breast cancer incidence, 62% reduction in overall mortality, and 2 versus 7 breast cancer deaths over a 6.3-year follow-up period in an international cohort. So surgery deployed preemptively based purely on genotype. This is the most literal expression of biologically driven decision making and the conceptual bookend to Halsted's anatomical model. Now, I will summarize in, I think, 2 slides. 130 years, 3 paradigms. Halsted's anatomical radicality lasted for more than 70 years. Then came the Fisher's understanding breast cancer is systemic. From 1990 onwards, there is a de-escalation, initially followed by surgeons, now being tried even by medical oncologists and radiation oncologists. We tried it in breast, we tried it in axilla. Now we are using from 2010 onwards, more of oncoplastic and nipple sparing techniques. Genomic assays came in 2010, which guide systemic therapy. And now neoadjuvant response and genotype-driven surgery is currently, which is practiced by most of us. So key take-home messages, ladies and gentlemen, is that Halstedian anatomical model dominated for more than 80 years, but plateaued in survival once the nodal and systemic disease was present. However, at that time, that was the best. So we cannot criticize it in hindsight because that was what gave the results at that time, and that stood the test of time for more than 7 decades. Then came Fisher's biological hypothesis proven by various trials, including the Mayan trial, which showed that the extent of local surgery does not govern survival once micrometastasis occurs. And 3 decades of axillary trials have shown that we can reduce surgical intervention in the axilla with less morbidity and as much oncologic safety. Margins, genomic assays, oncoplastic techniques, and neoadjuvant response are all expressions of one philosophy, which is biology is the king, not anatomic instinct, which dictates the extent of surgery. So the frontier, which is omission of surgery trials, genotype-driven prevention, they point towards individualized, minimized, or omitted surgery when biology permits, intensified only when the biology demands. Thank you very much.
Thank you, sir, for such an insightful talk with such a clarity. So I request you to please stay till the end, since we have the question and answer session in the last. My request to the delegates, please put your questions, if any, in the QA box, which we will be discussing after the 4th session.
See, these are some of the references which I have taken, so I can share this presentation and you can give it to the participants.
Sure, sir. Thank you so much.
Thank you.
With this excellent background, we'll move towards our next talk. oncoplastic breast surgery is just a revolution in the field of breast surgery. It combines the oncological principles along with the plastic surgery techniques. So to know the what, when, how of this important surgical technique, we have with us none other than Dr. Vedant Kabra, who is Principal Director, Surgical Oncology at Fortis, Gurgaon. Over to you, sir.
Thank you, Dr. Prekshi, and thanks to the whole organizing team, especially Dr. Vaishali, for inviting me here. I'll just start my sharing. Is my screen visible?
Yes, sir.
Yeah. Yeah.
Okay, so I've been asked to speak about something beyond conventional lumpectomy and how oncoplastic breast surgery has made a difference, as well as how do we plan oncoplastic breast surgery. So if we talk of evolution of breast surgery, Dr. Sinu, Professor Sinu has very nicely covered the science of breast surgery, which is mentioned on the left half, and then the art of breast surgery. So they used all sorts of things, including paraffin and silicone injections within the breast, obviously with horrifying results. But then we moved on to implants, flaps, and modification within the breast. And that is how the birth of oncoplastic breast surgery took place. It started in early to mid 1980s, and this term was coined by Odresh. After that, there were various classifications which have been used, but in 1990s, the use was not too much. It was quite sparse and scattered, but slowly in last 15, maybe 20 years, it has been adopted much more, especially in our country. And this article by one of the pioneers just mentions and clarifies what it has come to from oblivion to the mainstream. And what is oncoplastic breast surgery and how do we define it? There are very critical terms which are important. It's a form of breast conservation surgery that includes oncologic resection with a partial mastectomy. And I'm talking of oncoplastic breast conservation surgery here right now. Ipsilateral reconstruction using either a volume displacement from within the breast or volume replacement from outside the breast, and with a possible contralateral symmetry whenever it is appropriate. And that's a very concise and nearly complete definition given by American Society of Breast Surgeons. But the basic principle remains that oncologic outcomes must never be compromised. So the first step is we have to follow the oncological principles, and then next comes the cosmetic part. Both obviously have to be there together to have a good result. So my question is, are all breast surgeries oncoplastic surgeries? I am right now talking about breast conservation, but I would say yes, even a mastectomy is an oncoplastic surgery. We have to take care of our plastic surgery colleagues who are going to reconstruct with autologous, or if we are doing it by implant, how to do mastectomy, where to stop at the peripheries. And even if you are not doing immediate reconstruction, please keep in mind future reconstruction and plan your mastectomy scar as well as the extent of mastectomy accordingly. So even a plain simple mastectomy also has some oncoplastic principles involved. So why are we talking so much about oncoplastic BCS? We have been doing BCS for a long time, but these were the results which we got sometimes. So the one in the center is my own patient. The other two I clicked from patients who came to see me later on. And you can see the first one, the central one, this was a very good BCS to begin with, but as they undergo radiation therapy, you get this parrot beaking and all those things because the seroma collapses. And this was done in early 2000, somewhere around 2007-8, which is obviously unacceptable in today's time. What are the benefits? We definitely can excise widely. And this data is more to do with West, especially UK, that it reduces reoperations from 20% to 5%. In India, we have been in a habit of excising slightly widely because our patients don't accept reoperations. So our re-excision rates have traditionally been less than 5%. It can avoid mastectomy and increase breast conservation rate because we can excise larger area and then reconstruct that area. There is immediate breast reshaping. Obviously, there is better cosmesis and of better symmetry also as far as two breasts are concerned. It's a single procedure, so it avoids very complex and delayed reconstructions and BCS related deformities, the ones I showed in the previous slide. In a large ptotic breasts, if we use reduction mammoplasty, it reduces the breast size. So the delivery of radiation becomes better. The skin toxicity also reduces. And sometimes when we are doing symmetrizing reduction mammoplasty on the other side, you can accidentally discover a contralateral cancer, which would not have been discovered otherwise. And post mastectomy, now immediate or a delayed reconstruction, which is not part of my talk. There were several classifications. So there was an international consensus conference in 2017, and then there are various classifications like Klishna-Klow, which is the commonest one, Hoffman and Wollweiner. It's very comprehensive and quite complex, so I will not go into the details. And then there is American Society of Breast Surgeons, which is 2 levels based on volume displacement or volume replacement, essentially similar to Krishna-Klow, but in a different terminology. So level 1, according to Krishna-Klow, is amount of tissue excised. So if this is less than 20% of breast volume, there is no skin excision, simple reshaping can be done. There is no real plastic surgery training is required, and it basically avoids deformity. Level 2 is 20 to 50% of the breast is excised. There is sometimes extensive skin excision. Breast reshaping is by mammoplasty, and it serves to increase the BCS rate. So level 1 is basically to BCS is possible, but you are giving better cosmesis and deformity is not there. Level 2 is you are increasing the indication of BCS because you can excise larger area. The basic principle for level 1 is we have to undermine the skin extensively around the tumor as well. There has to be some NAC undermining as well, otherwise it will get pulled towards the side of excision. Full thickness wide excision up to pectoralis fascia, does not hold true very honestly, but if you are mobilizing pillars completely, yes, you have to go full thickness and then come and then bring the pillars together, but that doesn't hold true all the time. Pillar mobilization, it has to be biplanar or uniplanar depending on the kind of breast. So very cautious in fatty breasts, should not mobilize both the pillars. So both biplanes. Only one plane should be mobilized because otherwise the rate of fat necrosis is very high. And then you don't leave the cavity behind and there is glandular approximation or the immediate reshaping happens. Similarly, since you have mobilized under the NAC, the NAC's recentralization also happens. It is a very simple technique, very easy to learn. As I said earlier, also no need of a plastic surgeon, and it can solve actually most of the problems, especially if the breast size is decent and has very good cosmetic result. And in words of Krishna Klow, you learn it on Tuesday, try it on Thursday, and keep it forever. It may sound very simple, but we have to be very careful when we are practicing it. We have to be handling our tissues very well to avoid unnecessary fat necrosis. That's the one which I was talking about, a little more complex, and I'm not going into the details because largely what we use is either the Krishna Klow or the American Society. And here is volume displacement, where adjacent tissue rearrangement, which is level 1, or mammoplasty, which is level 2. Now, this is only volume displacement divided into level 1 and 2. And then there is volume replacement, which always becomes level 2 because you are taking autologous tissue from an extramammary site. So for example, a mini LD flap, a perforator flap, lateral thoracic flap. So, and then perforator flaps below also, these are intercostal perforator flaps and whole breast reconstruction. They would all come in level 2 oncoplasty. There are certain prerequisites and precautions before we embark on oncoplastic breast surgery. Patient factors, tumor or oncologic factors, treatment factors, and there are other factors, and I'll go into detail of all of them. Comorbidities like diabetes, obesity, connective tissue disorder have a bearing on surgery as well as postoperative treatment. So those who are diabetic, obese, are smoking will have poor healing, will have higher rate of fat necrosis, and we have to be very careful in mobilizing the breast tissue. Severe connective tissue disorder may contraindicate radiation use, so we have to again be careful. Any steroids and anticoagulants being used may compromise the healing, as well as a lot of bleeding and hematoma may happen. Previous radiation received, genetic predisposition, you may not, patient may not opt for breast conservation. Lifestyle and occupation. So what kind of reconstruction you're offering? Can we take LD muscle with the resultant loss of shoulder function? Or a lady who is very young, has not been pregnant, DF flap, people would not be very keen on using that. Similarly, where the disease is located, how many tumors are there, what is the extent of disease, and the biology of disease. If there is a need for neoadjuvant therapy, we must clip the tumors, otherwise we'll lose the site of the tumor and it will become difficult to clip them. I would also like to say something here. Many a times we are seeing patients who have come after neoadjuvant therapy. Clipping has not been done. Even a mammogram has not been done preoperatively. And then it becomes a challenge for us to offer BCS to those patients. They have had PET scan and then started with neoadjuvant therapy. Please remember, always do a mammogram, preferably an ultrasound also, and if required, dense breast MRI, and clip the tumor right in the beginning, or if it's a large tumor, maybe during the chemotherapy when it becomes a little smaller. Post-operative radiation again may affect the choice of radiation. Symmetrization, whether it is needed or not, and a big question is acceptance of symmetrization, because most ladies in India, if not really counseled hard, will not accept putting knife on the normal breast. They are happy to have some asymmetry, but they may not agree for symmetrization surgery on the other side. And then choosing and planning the procedure, marking, how to mark preoperatively, in what position, all those things have to be taken care of. And availability of equipment, especially Doppler for perforator flaps and microscope for microvascular reconstruction, and of course the expertise as well. Now, what's the size and shape, breast tumor ratio? Because if the breast tumor ratio is very favorable, we don't need fancy oncoplastic techniques and we can just do a simple mobilization and closure. What's the degree of ptosis? Because it will again impact the choice of your flap. Whether there is any existing asymmetry, and if there are existing scars which may hamper your placement of your scar, hamper the vascularity of the flap that you are taking, especially in reduction mammoplasties, which superomedial or inferior pedicle or superior pedicle. And then what is the placement of NSC, and how much is the breast density? Because biplanar mobilization is best tolerated in dense breasts. Also, counseling the patient becomes very important. The pros and cons, the options, the various options available, the complications that can be expected, cosmetic expectations. Mostly it has been seen that surgeons actually give it lesser rating as compared to patients. But then right expectations have to be set right up front so that patients do not get disappointed later on. Sensation and function of breast, again, very important, whether they will be able to produce milk and lactate. What about nipple sensation? These things are very important, especially in nipple sparing mastectomy. So I would suggest everybody undergo this or read this article from 2016 by Dr. Amit Agarwal, which very comprehensively shows these factors and how do we assess and then plan for oncoplastic and reconstructive breast surgery. Of course, record keeping is very important, and this is probably the most often shown slide for the choice of oncoplastic procedures depending on the quadrant. And you can see it's a small periareolar tumor. You can just do a crescent mastopexy kind of thing or a donut mastopexy. In a bigger tumor with a ptotic breast, we can do a mammoplasty, reduction mammoplasty. In superior pole tumor, ranging from say right breast, ranging from 10 to 2 o'clock, you can have omega mammoplasty or a bat wing mammoplasty, or even a hemi bat wing if it is a lateralized kind of tumor. And then various kinds of lateral medial J-plasties, vertical mammoplasties. This is basically the displacement technique within the breast and not a replacement oncoplasty. And that's similar thing, just summarized in a different way. What are the procedures that you can use for various quadrants. So for central quadrant, Grissotti, Batwing, Kozhol, Findlay, all those techniques are available. Round block technique, superior pedicle. I'll show some examples of the cases that have been done. So for central tumors, a very simple would be just remove it and do a purse string suturing. You can always do a central quadrantectomy also if it's a largish breast, but there is a flat mound that you will get, Grissotti, batwing, hemi-batwing, and then the perforator flaps like TDAP or a pedicle flap like LD flap. Superomedial quadrant, again, a difficult area for oncoplasty, also known as no man's land. There are various small procedures which can be done with a very good outcome. Superolateral quadrant, probably the easiest one because you get a lot of tissue lateral to the breast for various and various choices are available. So I'll just give you some examples now. Grissotti, I've already said it's for the central quadrant tumors up to 20%, 25% of the breast. But we must remember that the NAC IMF distance should be at least 7 centimeter. Better to have a denser breast because the vascularity of the mobilized segment would be better. If you don't have too dense a breast, then mobilize minimum possible and achieve that kind of closure. Closure when the adequate closure is possible, don't mobilize beyond that. Then alternative techniques could be a central quadrantectomy. I mentioned earlier, it's a very simple procedure, but with a flattened mound. This is a more complex procedure. I have never seen it also. I'll show a picture, but this is from a book, which is this one. I have not seen or done it myself ever. That's the Grissotti, which is for retroareolar tumors. So you remove the nipple areola. It's kind of a cylindrical resection. You go down to the chest wall, remove along with the fascia, and then the similar kind of mound of skin, a rounded skin below the nipple areola is taken. There is a large area of skin de-epithelialization that you can see here. And you mobilize this C. If you see the picture on the left, the C circle is mobilized into the D which has been removed, and A and B are brought together. That's one of the Grissotti flaps we had done, and this is a immediate post healing, and that's the result after radiation therapy. Central quadrantectomy, very simple technique, makes a breast smaller, but for elderly ladies who would like to preserve their breast and have a central quadrant with fatty breast, I think this is a very good technique with minimum fat necrosis and with acceptable cosmesis. Batwing is for the tumors I mentioned from around 10 o'clock to 2 o'clock position. And these are the various ways of drawing the wings. You can have a curved one or a straight one. That's one of the bat wings that I did. On the left side is a immediate post healing picture. On the right half is the post radiation therapy picture, and with a decent cosmesis and symmetry. That's a hemi-bat wing. This lady, your tumor is drawn in a circle and there are skin markings for hemi-bat wing. You can also see a small scar of the sentinel node biopsy. That's after excision going parallelly just down to the pectoral fascia and then mobilizing and joining everything together. And that's the cosmetic outcome post-surgery. Upper inner quadrant matrix rotation is a very handy technique because you don't get any of the flaps reaching that area, either perforator or any other flap LD. It's difficult for it to reach without causing a bulge on the other side. And some of them actually can't reach. So a matrix rotation involves removing a triangle of skin over the tumor and then a small triangle on the lateral side. A small triangle is removed. The whole breast tissue is mobilized to bring it back to close the cavity. And this is the kind of result you can get. It looks a little ghastly because it's a very large area of scarring in the breast, but it heals very well, and especially after radiation, it's quite okay and very handy for upper inner quadrant tumors. Now, J mammoplasty is basically for lower half or outer half tumors, sometimes even inner half. It's basically a combination of wide excision and mastopexy. overlying and sometimes a little extra skin excision with the tumor is required. Parenchymal reshaping is done by pillar mobilization and reapproximation. NSE is always repositioned by mastopexy, and ideally opposite symmetrization should also be done. And then there are certain alternative techniques like V-plasty for lower inner quadrant and perforator flaps for all these areas. So before the perforator flaps came in, it was used, J-mammoplasty was used. That's one of the examples of lower outer quadrant tumor. You can see it is combined with a mastopexy. That's the de-epithelialization. The trick here is you de-epithelize slightly more periareolary away from the tumor, because when the tumor is excised, the nipple areola gets pulled towards the tumor side. If you de-epithelize slightly more on the opposite side, it will get pulled on the other side again. And that's the picture post-operatively. Vertical mammoplasty for a 6 o'clock tumor along with mastopexy. This again is a just immediate post-op picture. Then chest wall perforator flaps. This is I don't go into the details of all that, but I'm just trying to tell you that it's a young lady, had multiple tumors, largish tumors, you can see on the MRI as well. Underwent NACT, had a good response, but there were 3 lesions seen, and these were the 3 lesions very close to each other. You can also see a scar mark there, which was of a previous surgery done few years ago, and which was fibroadenoma according to the histopathology in her own country. And this is how we excise the skin, because these tumors were closer to the skin. That's orientation going on. That's the defect. That's a sentinel node scar. And then a LICAP flap was mobilized into the defect, and that's the cosmesis. Another young lady, ERPR positive, low KI tumor, but a very small breast and a large area, largish kind of tumor was there, very young lady. So, and required skin removal as well, because it was close to the skin and breast was not very bulky. So it was a TDAP flap used for covering this area, and that's the kind of cosmesis we could achieve. This lady had a lower polar tumor, which was excised outside with a horizontal scar, and margins were also not clear. Of course, the cosmesis is also not good. So we had a challenge of not only excising the tumor, but also doing reconstruction there. So again, LICAP, ICAP combination was used, and it was reconstructed. This is again a lower polar tumor, excised. You can see the pedicle being shown with the forceps. In fact, it had 2-3 pedicles, and we could mobilize with all the pedicles inside. That's the whole flap in the center, lower central picture, and the rightmost picture is the final outcome. So all those complex things, sometimes we actually need to keep it simple. We don't need all those fancy things, and we can just mobilize the pillars or minimal mobilization and close it. So I'll show 2 or 3 examples here. This lady had a very large ptotic breast. Not only there was a tumor at one place, there was microcalcification extending far ahead. So we needed to excise a very large area, and this was going towards the NAC, but NAC was free. The subareolar tissue was also free as per the mammogram and the imaging. So we had a wire placed at the anterior most end. The other part of the tumor was palpable. This is how it was on table. A ellipse of the skin over the main tumor. And then we raised the whole skin, since this was a very large ptotic breast and she didn't want a very big kind of surgery or opposite symmetrization. This is what we do. And these cross marks that you see just above the areola, again, possibly these are the sites of the end of microcalcification, and the wire is going towards that side. That's the excision, pillar mobilization, and very simple closure around that. It's a specimen mammogram at the bottom showing that it has been very well excised, and that's the outcome. Another one, small areolar scar. You can also see a very tiny scar for the sentinel node biopsy. You don't need to do fancy things here, just mobilize little and close, and you can achieve a very good cosmetic outcome. Now, extreme oncoplasty for tumors which would otherwise require a mastectomy. Larger than 5 centimeters, typically multicentric tumors with some skin involvement. we have enough studies now to show that extreme oncoplasty can be practiced, but we should be extremely cautious before we embark on it, and patients should understand the implications of getting converted into mastectomy or slightly higher local recurrence rates as well. This was a long time back, 2002, when I was actually in training in my final year at Tata. This lady had a very bad skin involvement, post neoadjuvant, beautiful response, but a lot of scarring of the skin. So we did a mini LD that time, and she followed up much later with a very good outcome, and cosmesis is still there. But these are exceptions rather than the rules. And this was given by Dr. Vaishali Zamre. We know that breasts will come in all shapes and sizes, and we have to tailor our surgery according to what we have and what that particular patient has. You can have a small NSC, very large NSC, very ptotic breasts, very small ones. So then we have to tailor our surgery accordingly. So oncoplastic breast surgery is basically a combination of oncological principles, which obviously come first, then sound plastic surgical techniques, and when they marry each other, we have oncoplastic breast surgery. Thank you very much. I'll leave you with this thought from Dr. Silverstein.
Thank you, sir. Such an excellent portray of such complex techniques. So, being non-surgeons, we are not able to understand much regarding the techniques, but yes, the cosmetic outcomes are definitely very good. So, thank you, and please, if you can stay till the last.
Yes, I have to unshare also, but somehow it has gone away. My screen has gone. I can't see the Zoom window. I'm sorry.
Sir, you have stopped sharing.
Really? Okay.
Yeah,
Good. Thank you.
Sunidhi, can you move forward? So next, we know that the role of neoadjuvant systemic therapy in breast is ever increasing. So it may lead to downstaging of the tumor, may lead to good cosmetic outcomes, higher PCR rates, but many times it becomes difficult for the operating surgeon. There are some challenges. And to navigate through those challenges, we have with us our very own Dr. Geeta Kadayaprath. Ma'am is currently leading at Apollo Athena. Over to you, ma'am.
Thank you, Prekshi. I hope I'm audible.
Yes, ma'am.
So there may be a problem with my internet. Just let me know. Okay, so let me share my slides. Can you see my slides?
Yes, ma'am.
Okay. Oh gosh, I'm getting a lot of these post things. So, you have already heard times that we live in, because, I think the worst bit of how much you can offer a patient is over, because mastectomy for all is not the option. So you have to think conservation. So conservation is not just limited to primary surgery. Now we know that we have extended conservative surgery to those patients who undergo neoadjuvant treatment. So I bring greetings from Apollo Athena, and I thank Dr. Arun Goyal and Dr. Vaishali for having me here. And you've been able to carry on this wonderful endeavor, while we kind of had to stop because of various reasons. But it's always easy to start something, but to sustain it and sustain it well is a difficult task. So while we talk of neoadjuvant chemotherapy, it is not the best of things that surgeons like, but we do know what happens with neoadjuvant is that you have increased pathological complete response. And of course, it has forced us surgeons to reassess strategies, especially in those patients who are triple negative breast cancers and HER2 positive cancers. Of course, we keep worrying about what is the optimal timing, although in our country, I believe we are pretty good with it, especially in the private sector, not so much maybe in the government sector, because of the deluge of patients that they see. And surgical de-escalation is the buzzword for surgery. And just as Dr. Sinu said, it is a concerted effort to kind of put the surgeons by the wayside, but we are happy if it works well in the favor of the patient, then why not? So both in the breast as well as the axilla. And of course, the question to ask at the end of it all is really surgery out on its way out? So what are the practical aspects that one needs to keep in mind for surgery after neoadjuvant systemic treatment? So I will just stick to the mandate that was given to me, because I think surgery after neoadjuvant treatment is a different ball game altogether. There are various things that need to be done at the time of initiation of neoadjuvant systemic treatment. Just as Dr. Vedant said, there are times that you see that there's this patient who has excellent response and wants a breast conservation, but nothing was done prior to offering it at the time of initial treatment, which was the systemic treatment. So one has to be very, very cognizant of the fact that you have to do those essential bits at that time, because when a patient comes later, it is not possible to offer conservation, especially if there has been complete response. So I do tell patients, the patients at the beginning who are so caught up with the disease, they say, no, I want to have mastectomy, I don't want anything else. But I keep telling them, look, you're going to change your mind. And if you do change your mind, I will not be able to offer you conservation if you don't have a clip placed inside the lesion. So there are various decision points that we need to worry about at the time of surgery after neoadjuvant systemic treatment. What about the overlying skin? What about margins? What is we keep talking about clipectomy, although I'm not a big fan of clipectomy, versus the footprint. Bracketing essentially, if I do wish to do a conservative surgery, how am I mapping my tumor at the beginning? That becomes very, very crucial. And then extreme oncoplasty, which again Dr. Vedant had touched upon. With oncoplasty, we have been able to broaden our horizons. We have been able to excise more because we know we can fill it up. And then, of course, the other extreme is no surgery at all. Of course, we are at this investigational frontier, but not quite there yet. So why post-neoadjuvant surgery is a different problem? So, when you see a radiological complete response, it does not necessarily translate into complete response. And like I said, I cannot stop emphasize for you trees that we mark, even we still, but at least allows the radiologist to guide us to where we need to go. And we have extremely high PCR rates with triple negative breast cancers and HER2 positive, and with a more concentric response. Although when you look at hormone sensitive tumors, we do see that it is less predictable. It is not very often that you see a complete pathological response. So these are the two ways in which the shrinkage can happen. It can either be concentric, where the tumor shrinks inwards and the original footprint almost completely disappears. And then there is the scattered manner, wherein there is shrinkage. Up to 39% of responders will have viable nests which are kind of there in the original footprint. So if the original footprint is intact, despite the fact that there has been there are small areas of involvement, you should look at the original footprint and not look to reduce your size of excision. Then, of course, we talk about the skin envelope. Is it necessary to excise skin every time you do a surgery post-neoadjuvant? Well, that's not necessarily true. But if there has been a lot of dermal involvement, and if there is, say, limited peau d'orange, and it is persisting even after your chemotherapy, if it does not resolve, and if you can see that the skin was adherent to the tumor at the time of imaging and even examination, so these are areas where you would want to kind of take the skin, but otherwise you don't necessarily have to do that. And you also get, in our situation, we also get those patients who have ulceration which heals on neoadjuvant treatment, but you still have to take away that skin. So I'm just throwing the spanner in the works. Inflammatory breast cancer still does not really qualify for breast conservation, but there are papers and trials which are looking at this aspect. And there is inflammatory breast cancer, but the skin envelope is not really that big, then possibly you may consider it, but otherwise, for all practical purposes, we must keep inflammatory breast cancer off the plate. So now the other important aspect is margins. So the no ink on tumor that we talk about for patients who have in primary tumor holds good for those patients who have residual or complete response even after neoadjuvant chemotherapy. So that is important. So they have seen, there is this study where they have seen whether there is any difference in 5-year local recurrence or disease survival or overall survival when they compared less than 1 millimeter or to more than 1 millimeter or pathological complete response. So these three things have been compared and they have found no significant differences. So we are fortunate in our setup that we have got frozen sections. So we do, of course, do intraoperative frozen section, and that is a brilliant thing to do, I think, because the pathologists often are able to identify the tumor bed and can report on margins from the tumor bed. So these are very, very important caveats. Then we come to this clipectomy. So how do you decide the extent of resection? So clipectomy is essentially reserved for those patients who have brilliant response and all that you're seeing is clip and a little bit of soft tissue around it. It's been a concentric shrinkage. The radiology is absolutely brilliant and there is hardly anything to see. So in those cases, one may consider it. But I am a very conservative surgeon. I am not a clipectomy advocate, although they say with HER2 positive and triple negative breast cancers, one may kind of look at reducing the amount that you excise after neoadjuvant chemotherapy. But if there is a Swiss cheese pattern of response, it is scattered, it is multifocal, or there has been an area of, say, microcalcifications in relation to the primary tumor and the microcalcifications are still there, has been marked by your radiologist at the start of neoadjuvant chemotherapy. So in those patients, you would want to do the original footprint excision. But like I said, the bracketing of these areas are very, very important even before you kind of embark on this kind of excision. So what we do with bracketing is, it is possible, various people do it differently. So some people put 5 to 6 clips all around the circumference. But what we would do is, there are ways to do it. I will just come to a case and show you how, if you place 2 to 3 clips judiciously, you can still be able to mark out the entire tumor extent. And once you place the clip, whether it is for multifocal tumors or the microcalcifications, you must go back and reassess. And once the treatment or the systemic treatment is done, you must get your radiologist to place wires to the clips, or if at the moment we do not have the non-wire options, but wires are good. And you must excise from outermost clip to outermost clip after a wire localization of these clips. And we have been doing this regularly for larger tumors. And if there is scattered shrinkage or multicentric disease. So this is, but of course, one has to look at whether we can actually tailor the excision to the true pre-treatment extent to reduce positive margins and unnecessary large resection. So there is a prospective trial happening to compare wide versus narrow bracketed margins. So like I said, there are various methods to identify, to localize the area of interest. Wire localization is what we use, but then there is the reflectors, the radar reflectors, magnetic seeds. These are not available to us as of now, but this will be a great add, because then you don't have to necessarily depend on the radiologist's schedule to kind of place the wire, and these clips can be placed possibly even at the time of starting the neoadjuvant treatment, and that can guide your excision. Radioactive seed, yes, but again, disposal is an issue because this is radioactive. And once you have done this, then you must get a specimen mammogram done to ensure that your bracket clips are out, and it should be accounted for before closing. And what we would do is, once we've done the specimen imaging, we also do a frozen section so that we are doubly sure that we have got the entire tumor extent. Dr. Vedant has already touched upon extreme oncoplasty. So I always think it is a good add to our armamentarium, but be very cognizant of the fact that it is always oncology over oncoplasty. And this has been Silverstein's mandate, and we have also done quite a few extreme oncoplasties. And that comes primarily from the idea that we know that we can take care of a large area of resection with an appropriate oncoplastic procedure. So I'm just showing you this picture where this lady had 2 tumors, but if you can include it in the resection specimen, that is fine. But because if you use a pedicle, you can actually push extra tissue. A secondary pedicle can be used to push tissue in lateral aspect, which would be hollow after doing a reduction, and you can get that kind of result. So this is another patient. This is post NACT 2 lesions, and you can see the 2 wires going into those lesions, and we did an eye cap flap and transferred the flap into the defect as a horseshoe. And this is the immediate post-op image. As you can see, the swelling in the upper outer quadrant, but these are the follow-up images. You can barely make out the breast on which the surgery was done. So let me just take you through how we do the bracketing through one case. This is a 38-year-old, ERPR positive, HER2 negative, node positive. So she had multifocal, multicentric, although just across the meridian actually, and she desired BCS. She was quite certain she wanted breast conservation. So this is the mammogram. You can see the lesions on the mammogram, and this is the ultrasound showing the multifocal disease and the lymph node. So the biopsy was done. This was IDC grade 2, ERPR strongly positive, HER2 negative, FISH negative, FINACE of the lymph node was positive. So this is the MRI. So you can see the extent of the disease. You can see 2 lesions, there are multifocal lesions, another one sitting a little away from it. That's the PET scan that also catches the multifocality of the disease and the axillary lymph node. So this lady, because of the nodal positivity, young age, and the biggish area of involvement, underwent neoadjuvant chemotherapy followed by surgery. Then of course the question is, do you do breast conservation or MRM? But like I said, the patient was hugely desirous of a breast conservation surgery. And why not? Because she's a young lady. So now look how these clips have been placed. And this is what I meant, that one clip can actually give you a direction or in 2 planes. So when you do a CC, you're seeing the lateral extent. On the MLO, it is giving you the inferior. So this is marking the inferolateral extent of the disease. And the second clip, which is medial, is that was the supralateral, and that is the inferomedial. So this clip is marking the medial and the inferior extent of the disease. So this lady had neoadjuvant chemotherapy, and after completion of neoadjuvant chemotherapy, we had to do a surgical assessment. So you can see post neoadjuvant MRI shows minimal enhancement around the clip. And that is the post neoadjuvant clips that you can see. And you can if you look very carefully, you can appreciate the microcalcifications also around that clip. So like I said, when you have microcalcifications, they have to be very, very accurately mapped, because you don't want to leave any of that behind. So this is how it looked like. This was tomo-guided wire localization of the abnormality. So you can see the extent. And the wire is sitting right there, and the lower wire is actually the lowermost extent of the microcalcification. So she's a 34B with moderate ptosis. So that was the area that we had to excise, and that is the flap that was designed, which is the L-tap R-cap flap. So that is the flap inset, and that is the specimen mammogram. So you can see very carefully, if you look very carefully, you will see all the microcalcifications. Those are the two clips that have come out, and those are the clips that are marking the margins. So this lady's final pathology, the tumor bed size was about 5 into 4.5 into 3 centimeter with a residual invasive carcinoma of 1.5 millimeters. All margins were uninvolved, and one node showed micrometastasis. So she's been very lucky considering that she was a hormone sensitive tumor, and she has kind of responded very well to treatment. And this is how she looked like on the post-op day 10. So the last question that, not the last, the second last question, of course, optimal timing of surgery. So we all do surgery at 3 weeks, but 4 to 8 weeks is what is the ideal time to do surgery. So there is a meta-analysis including 5 studies. So 3 out of 4 studies showed similar recurrence-free and overall survival in 4 to 8 weeks. One study showed improved PCR if you waited till 8 weeks. Well, I don't think we would want to do that. But there was another study which kind of endorses what we do, and that is 21 days. And this time to surgery was also an independent predictor of recurrence-free survival and overall survival. So no surgery at all is the lane that we are kind of heading towards, but so far the results have not come up with something brilliant which would allow us to not perform surgery. So this is the NRG BR005, the micro study and the responder study. So these are VAB-based excisions, and these biopsies had a sensitivity of only 50% in the NRG BR005. In micro was a core biopsy based study, and again lower accuracy in this study. Also not safe to omit surgery is the mandate. And responder, so VAB based algorithms, so AI directed algorithms is what one is looking at, and it is possible that things will change as we continue to get better at it. So this is a practical decision flow, what you should do before neoadjuvant chemotherapy. This is what I would leave you at. Restage after neoadjuvant chemotherapy. Look for a response. What kind of response do you have before you decide how to excise? And a complete clinical response should set you thinking in terms of whether you should omit surgery or not. But of course, we have to wait for a little longer before we see anything exciting happening in this area. Thank you very much. These are some references, but if you share my slide set with the participants, they can read more about all of this. Thank you very much.
Thank you, ma'am. Ma'am, do you want to say something? Vishali, ma'am? So thank you so much, ma'am. There's an information for the delegates that we have a YouTube channel under the banner of FSIBC, where we are putting and will put all the presentations. So if you want to have a look afterwards, then you can please visit the site. So next we'll move towards breast reconstruction. So it is actually an integral part of comprehensive cancer care, and there are multiple aspects to this, like what is the right timing, who is the right patient, and which technique to be used. So to discuss all these, we have with us young and dynamic Dr. Dilip Koisal, who is from TMH. Over to you, Dr. Dilip.
Yeah, good evening. Thank you, Dr. Prekshi. Thank you, Vaishali ma'am and Arun sir, for this opportunity. I'd like to share the screen. Will I be? Yeah, just a second.
So you can share, you have access.
Yeah. Is my slides visible?
Is loading, sir.
About to be. Yeah,
Yes.
they are.
Yeah. So my slides, I hope, are visible.
They are, and
Yes.
you are audible
Yeah.
also.
Yeah. Thank you, Vaishali ma'am and Arun sir, for this wonderful opportunity. It was wonderful to listen to, as usual, to Geeta ma'am, Vedant sir, and Seenu sir we've grown up listening to all my teachers. Thank you so much for this talk again. So I'll get moving. Vaishali ma'am gave me this topic, redefining mastectomy, the convergence of conservative resection and immediate reconstruction. Now, when I first thought, how do I think about going about this? So then, how did we evolve? So the key to our scientific future is hidden in our past. This is what Dan Brown said, a famous author. Now, when I started off with searching the topic, so first I thought, what is mastectomy? So what do you mean by conservative mastectomy? What is mastectomy? So it all started with Halsted. So we all stand on the shoulders of the giants. So he is the one who showed that with such ghastly surgery you can still have a cure. So that is something which was unheard during those days, and it was unheard of ki the breast cancer can be saved, a patient can have a prolonged survival, or they can be cured. So from there we had these kind of patients who came along, and in 1960s and 1970s came Dr. Bernard Fisher, who was a revolutionary with trying to incorporate other forms of treatment into surgery. And he came up with this NSABP-B04, which said that it is not always needed to be so radical. And from there on, now we've come to simple mastectomies, conservative mastectomy. What exactly a simple mastectomy means? It removes the entire breast tissue, including the breast tissue, nipple, areola, and the overlying skin. So with this, a new term came up in somewhere around 2000s, or a little late 1990s and 2000s, that is conservative mastectomy. To be precise, this is like an oxymoron. How can be a mastectomy be conservative? So that is what actually we feel when we are actually thinking about a mastectomy. So what I tried to find out who actually coined this term. So when I went back, it is from the University of Naples from Italy, who actually it led to their papers from Nava et al., where they have described this entity, where they said that it is again removal of the entire breast parenchyma, saving the outer covering of the breast only if it is oncologically safe, that is subcutaneous fat, skin, and nipple. That if it is oncologically safe, you can save them. Now, with the possibility of performing an immediate or a two-stage implant-based reconstruction or an immediate autologous tissue reconstruction. Now, with this, the conservative mastectomy had various types or names. The way we call it, skin sparing mastectomy, which was described in 1991 by Toth and Lappert, and a nipple sparing, which was actually previously done in 1951 or described in 1951 by Rice and Stickler. They were actually doing it for benign conditions called as adenomamectomy during those days. Now, in large ptotic breast where the skin would be excessive, even to replace the tissue within, so they started calling it as skin reducing mastectomy. Now this subcutaneous mastectomy, which has been there for quite some time now, it is used as arguably used interchangeably with the nipple sparing mastectomy. This is what actually it means. What are you going to preserve and what are you going to remove? In skin sparing, everything else is removed except for the overlying skin. And whereas in nipple sparing, you save the skin as well as the nipple. And these two surgeries are done in usually well selected patients. Now, how did the evolution of NSM and SSM happen? So during early 1970s and 1990s, there was a huge emphasis on trying to conserve the breast, trying to conserve whatever was not diseased, and that's where Toth and Lappert came with their paper after the NSABP B04 and the B06 initial papers, which actually came in 1977 and 1985, and they came up with this idea that if the skin is not diseased in early stage breast cancer, we can actually save them. So then thereby again they started, the genetic testing was started, and in Mickey and Oster they discovered this BRCA in BRCA patients, who actually where we can try and see if they can be used for prophylactic mastectomies. And Larongo presented in Annals of Surgical Oncology in 1999, and thereby all the other papers. Now, where this NSM in a therapeutic setting, that is in a stage setting of cancer, is still being debated whether it is safe or not safe, whether it is really to be done or not to be done. But I think now it is almost put to rest that yes, NSM can be done in patients who have breast cancers. Now, what are the indications of conservative mastectomy? It can be multicentric disease, it can be extensive malignant microcalcifications, persistent positive margins, and for risk reducing strategies. What are the contraindications for a skin sparing? So the inflammatory breast cancer is one of the contraindications for skin sparing mastectomies. It is still not being considered even if they have excellent response on. We come across very commonly these inflammatory cancers responding very well to chemotherapy, including the targeted therapies, but yet it is still not an indication for skin sparing mastectomies. Now, if there is extensive skin involvement involving more than two-thirds of skin, again, it is again a contraindication for us to actually go and do a skin sparing mastectomy. Now, how do we plan the skin incision in a skin sparing mastectomy? Now, the Gonzalez et al. And the Rancati, the stalwarts of these conservative mastectomies, they have described it in five types. So, type 1 is where we actually uh, Type 1 is where we actually save the go around the nipple and take an vertical down, and then you remove the nipple along with it, and along with that you remove the entire parenchyma. And this again can be done for the perioral tumors. Now, if there is a scar like this where there is a medial or a lateral extension which is needed in a ptotic breast, then you take it around the areola and then extend it laterally. Now, in a type 3, you have a previous site of surgery and that needs to be excised. You take a perioral incision, go along with it, and then take a ellipse along near that scar and then take it out. And in type 4, it is for the elliptical or large ptotic breast where you want to reduce the skin as well as remove the nipple. So you can it is always taken as an ellipse in the lower outer quadrant. Now then came the type 4 inverted T, where you can use the vice pattern markings, but you don't have to keep the flap. You don't have to keep the nipple. So you just excise that everything that is coming below that level of the marking, and your final end product will be just a simple inverted T. Now this inverted T is actually
Sunidhi,
Yes, ma'am.
can you check with Dr. Dilip because we have
Yes,
stopped
yes, ma'am.
seeing
I'm
his.
calling. I'm calling, ma'am. I'm calling.
Okay. I think he seems to have logged out also.
Zoom has crashed. I'm sorry. My Zoom has crashed. I'm really
Okay.
sorry, madam. I'm just
Okay,
trying
no
to log in.
worries. Sure, sure.
If I can have the slides, I can present it from here, ma'am, from the phone. Because
Okay.
my
Uh,
Zoom on the desktop has crashed.
okay.
Sir, I just
Sunidhi?
need the access, sir.
Is that possible, madam?
Sir, I'll share from my side. You just
Sure.
instruct me.
Okay.
Sir, are the slides visible?
Yeah, slides are visible. I'm extremely sorry. It just has crashed.
Just instruct me to stop, sir.
Yeah. So till where was I presenting? Had I discussed the skin sparing mastectomy incisions?
You were talking about the skin reducing procedure,
Yes,
the
ma'am.
type 5. Yeah, that is where
Okay.
you were when we stopped seeing your slides.
So that is slide number 13. Yeah. The I think this will be the yes.
Ha, yeah, yeah.
Yeah.
The F, the type 5, type 4F.
Type 4.
That
Yes,
is,
yes, ma'am.
yeah.
So I'm extremely sorry. It just crashed. I don't know. It's probably because of the rains or whatever it is here at my place. So the type 4, where you have an inverted T shape, is where you can actually use the vice pattern markings so that we can excise everything else, and we need not keep the nipple if which is involved or which is at a risk, or if the oncology is compromised, and thereby just closing it like an inverted T. Next slide, please. So now, whenever we are doing a skin sparing mastectomy, the important thing that we are always concerned is the flap thickness. Now, the length of the flap will almost be for almost about 20 to 25 centimeters from the suprasternal notch, and it is a thin fold or a thin flap of tissue, and it has to survive the length that it is coming along, and the intercostal arteries are exceptionally good. The anterior intercostal, which come up from the internal mammary artery. But however, saving a good flap thickness, which is about 5 to 8 is what has been described in the text. But it also needs to be understand that we need to have a uniform thickness of the flap from the beginning till the end. It should never happen that the initial thickness of the flap is thick. As you go down, it becomes a thinner flap, which is actually dangerous and can cause vascular insufficiency. Next slide, please. So now, in any mastectomy, or especially in a skin sparing mastectomy, there are some no-go zones. So we need to stop exactly on should never exceed beyond the level of the clavicle. Laterally, not go beyond the anterior axillary line. Medially, never cross the sternum. Inferiorly, never again breach the internal inframammary fold. Now, doing this, these are the vessels which are actually supplying the all the flaps from all around, and they are actually having a very good anastomosis at the level of the subdermal plexus. Now, if we damage any one of them, it would unnecessarily lead to a lot of issues with in terms of maintaining the complication. And if we are placing an implant or a autologous tissue underneath, and it is we are putting it under a risk or a flap failure. So that is the reason why going or maintaining a strict vigilant of where and how much we are dissecting is extremely important. Next slide, please. Now, what are the indications? The indications again I have spoken previously also. Now I brought this slide back again here because the next slide is very very important, where it is about the nipple say sparing mastectomies. Now the NSMs are even more trickier. So now these have a specific indication, and now the indications are extremely are becoming extremely specific, because it need the patient selection is it is very, very important. Now we have a multicentric disease without any skin involvement, extensive microcalcification, persistent positive margins, and risk reducing strategy. These are the classical examples where we can do these procedures. Next slide, please. Now, where am I not going to do a contra or not going to do a NSM? That the contra. What are the absolute contraindications for a nipple sparing mastectomy? Now, the NAC involvement in any form, either be it clinical, radiological, or a pathological evidence, we should never attempt a NSM. Now, here the rates of local regional recurrence will be exceptionally high. Should not be done, because as we have seen, as these data suggest that whenever there is a incidence, the incidence of nipple recurrence is extremely high. It's almost up to the tune of 47%. Now, if there is a positive nipple undershave, do not save the nipple. If there is a inflammatory breast cancer, again, do not save the nipple. Paget's disease, index T4B disease, they are not cases where we should be attempting an NSM. Now, what are the relative contraindications? Next tab, please. Yeah. Now, what are the relative contraindications? It's smoking. The comorbidities like diabetic, uncontrolled diabetic, hypertensive, IHD, has poor effort tolerance, has poor ejection fraction. These are patients where we should avoid doing such a thing because their vessels are at risk. So they may not have a healthy vasculature to support the procedure per se. And in large ptotic breasts, yes, again, as I said, it has to travel so long. If we are having a large ptotic breast, there's no point in saving such a huge skin envelope where we cannot fill it or even try to match it up. Now, the tumors close to NAC, again, this is again a relative contraindication because some papers suggest that it can still be done if the nipple undershave is free. So the next slide, please. Now, how do we plan an incision in a nipple sparing mastectomy? So whenever we have got a patient who is eligible or who is who qualifies for a nipple sparing mastectomy, we can always utilize these incisions. The usual or the most commonly performed is moderate ptosis or a small sized breast is the inframammary incision, where you can easily take up the incision and take the entire thing out and preserve the vasculature to the nipple. Now, if we do a periareolar and a lateral extension, like it is shown in figure A, then it is also good enough. But there are certain times when you're raising these flaps, there is at times that the thickness of the nipple can or the areola can become extremely thin and can be subject or can be having a risk of nipple necrosis. Now again, B is again just around the nipple taking and then a lateral extension, and the type C or the C is figure C is almost a transverse incision on the nipple, and E is where you have a lazy S kind of an incision in the lateral extension, so that you just have to exercise everything all around the breast parenchyma has to be mobilized and exercise, and it also allows you to do an axillary procedure if it is indicated. Next slide, please. Now, how do we, this is an interesting thing. How do we do the NAC dissection? So are we just going to cut off, or are we just going to take it out, or can we use a cautery? So this is nicely described here, where you inject saline into the nipple areola complex, do a scissor dissection, that is a sharp dissection. Do not use cautery because the vessels in and around this nipple are extremely sensitive, and each thickness of NAC varies with the vascular supply that it has. So it is extremely important for us to dissect out the NAC nipple areola complex, dissect slowly the ducts, and thereby you can easily see that in the last picture that there is a mound of nipple which is there on the specimen. So now the thickness, if it is less than 2 millimeters, the chance of nipple necrosis is very high in those patients where we are doing a nipple sparing mastectomy. Next slide, please. Now, how do we manage, or how do we know that the nipple is not involved in any case that we are doing for a therapeutic resection? That is where there is a cancer in that particular breast. So all the patients undergoing a nipple sparing mastectomy having a disease in that particular breast have to undergo a nipple margin assessment or a nipple undershave. So now if there is a now if there is a nipple which is actually involved, we always try to excise it, and it cannot be saved. Now whenever we are planning a patient for an NAC, we do an intraoperative frozen section of the undershave, and there is a negative for once it comes out as negative for malignancy, we can save the nipple. If it is positive, then excise the nipple. Next slide, please. Now, is it really oncologically safe? How we are doing saving the nipple? We know that this apis plexus is very rich in and around the nipple. Now, the breast cancer usually spreads with lymphatics. Are we really safe in saving a nipple in a patient who is already having a cancer? Now, what does science say? Is it really okay to leave behind the nipple, or is it really not safe? Or are we taking a chance by not taking care of the oncology and just doing a nipple sparing mastectomy? Let's see how it goes about. Next slide, please. Now, a nipple sparing mastectomy, we have seen that in 320 patients who had a SSM or an NSM, they had an equal loco-regional recurrence as compared to a non-SSM or an SSM. Now, the native flap necrosis is about 10.7% and 11.2% for those who are having an SSM and a non-SSM. Now, this is for the skin sparing part. For the nipple sparing, there are specific considerations which we need to look into. Next slide, please. Soiler in 2008, he looked into, he dissected those nipples and looked if there are any terminal ductal lobular units. And now we all know that the breast cancer arises from the TDLU. Now he wanted to see if the nipple and areola complex had any TDLU. Now, they saw about 22 patients. In those 22 patients, they saw about 29 specimen which did not have any terminal ductolobular units, and only 3 had one out of it. So they just suggested that in a risk reducing surgery for an NSM, you can safely do a nipple sparing mastectomy. Next slide, please. Now, the second thing was, where do I save this? In which conditions can I save a nipple areola complex? Now, they in a study done by Logic et al., it showed that tumors less than 2.5 centimeters and a tumor to nipple distance of more than 4 centimeters can be safely preserved. Now, these are the areas where we can utilize to select our patients for surgery. Next slide, please. Now, neoplastic involvement and nipple and skin flap, even in all cases who are having a carcinoma breast. Now, the larger tumors have the highest rates of occult nipple involvement. Now, a tumor size smaller than 2 centimeters has about 10% chance of having an occult nipple involvement, and 2 to 5% of them have 2 to 5 centimeter has about 13 to 13.3 percentage. Now, if the size is more than 5 centimeters, it rockets to about 31.8 percentage. Next slide, please. And all these papers are all seminal papers, though they are a little old, but they have been extensively studied where the nipple is being involved. So now the analysis of nipple areola involvement in a mastectomy, can the areola be preserved? Next slide. The next tab, please. In this, they saw that the nipple was involved in 27.3% of the patients where the tumor was located retroareolar. For other quadrants, it was only about 6.4%. Next slide. So nipple preservation during mastectomy was studied by Kissin and Karp. Next slide, please. Next tab. They reported a higher nipple involvement when the tumors are located within 2 centimeters from the areola margin and in women who had 4 or more positive axillary nodes. So these are the two indications which are again relative indications, because we are getting the recent data coming out where they are saying with the advent of newer chemotherapeutic targeted therapeutic agents, these things are being taken care of, is what is suggested in the literature. Next slide, please. Now, all in all, what are the considerations? Tumor to nipple distance should not be less than 2 centimeters. It should be more than that. If there is a lymph node metastasis, that's a higher risk of occult nipple malignancy. If there is an LVI, if there is an extensive intraductal component or an extensive microscopic microcalcifications and a retroareolar location. These are the cases. If we are starting off to do these NSM, we should be a little wary of choosing such cases in for an NSM. Next slide, please. Now the meta-analysis has shown that an NSM is as good as any regular MRM or an SSM, which having significantly, a non-significant differences in terms of OAS, DFS, and local regional recurrences. Next slide, please. Now, with all these data coming up, we know where we can do an NSM. Now, once you have done an NSM or an SSM is done where you're planning to do a reconstruction. That is a post-mastectomy reconstruction. Next slide, please. Now, what are the goals of reconstruction? What are the goals of immediate reconstruction? You're trying to give a naturally appearing breast mount, adequate volume and projection, symmetry with respect to the contralateral breast, and to restore or try to recreate the nipple areola complex. Next slide, please. Now, why this discussion really needs to happen with the patient? Now, one, it has got a significant psychological impact because they start feeling that they're not feminine anymore and are not liked by their family and friends anymore, or they start developing those inferiority complex which needs to be addressed. Now again, a social stigma where it affects their sexual and well-being, the life, the motherhood, the breastfeeding, and all of it. So that is where it needs to be discussed upon. Now the third thing is the marital role. Now if they start to feel that if there is no second, if there is no breast that is there, they start getting into that zone of, okay, fine, I'm not looking great, I'm not sexually attractive anymore. And these are the things which will make the life of a woman extremely difficult for her to have a day-to-day normal living. So the discussion has to happen with them. Next slide, please. Now, what are the various options or various ways we can do a reconstruction? I have not included the other factors like the surgeon factor or the social factors. Considering an ideal situation, we need to take into account the patient factors. That is, what is the extent of disease? What is whether it is oncologically safe, or is the reconstruction going to delay her adjuvant treatment? So all these things needs to be considered, and in that we have an immediate reconstruction, we have a delayed reconstruction, we have a delayed and immediate reconstruction, which is proposed by the MD Anderson team. Next slide, please. Next up. Now, what are the types of reconstruction? It can be either autologous or an implant based, which is pedicled or free flap. For an autologous and for an implant, it can be a one stage or a two stage, where you put a implant expander in the first stage and then put the implant in the second stage. For a one stage direct to implant, you use either a muzzle or an ADM, that is acellular dermal matrix, or a dermal sling to put an implant in the reconstruction. Next slide, please. What are the types of reconstruction, that is implant and autologous, which we have discussed this, and it show what are the various flaps that we can take. One is an LD flap, one is a PAP flap, one is a gluteal artery flap. Then we have the free flaps which comes up from the DF flap or various other places. Next slide, please. This I've already described. Next slide, please. A pedicle flap is nothing but one which moves along with its pedicle to the recipient area, whereas the free flap is where the vessel is completely cut off and then reanastomosed in the recipient area. Next slide, please. Yeah, now autologous versus implant. I'm sorry, the previous slide I didn't touch upon the advantages. Now, both implant based as well as autologous have their own advantages and disadvantages. Implant being less operative time, faster recovery, faster, fewer complications, shorter learning curve. The disadvantages being capsular contracture, higher rate of infection, less natural feel, and there are some illness where because of the breast implant there is a constant foreign body effect seen, and that's called as breast implant illness. Now we also have the anaplastic lymphoma, which is there, which is recently being reported in the literature. Whereas when you come to the autologous, its advantages being use of own tissue. It also gives another second tummy tuck operation in the same sitting. Those who, it is more resistant to radiotherapy, and chance of rejection is very minimal until and unless it becomes extremely infected. Disadvantages being it is technically more challenging, long surgery, longer recovery, and more short-term complications. Next slide, please. Now, both autologous and implant have their own strengths and weaknesses. It is prudent to understand both the advantages and disadvantages of both. A shared decision making is extremely important between the surgeon and the patient. Next slide, please. The oncological outcomes for if what happens if I am doing an immediate reconstruction, is it delaying the treatment, or is it okay to do the immediate reconstruction and then treat her with the adjuvant treatment? Now all these studies have shown that it is equivalent and can be done at the same setting, and so immediate reconstruction will avoid a second surgery, and the outcomes are much better than when compared to the secondary reconstruction. Second, next slide, please. Now, okay, as a doctor, as a this one, I reported everything. Everything looks fine. Everything looks great. Even the oncologically, it is fine. Now, what is the other side's perspective? Is patient really having a benefit? Is there a difference in their feeling? Is there a difference in the way they see? And this is one thing which has been reported by Santosa et al. They questioned about 1,200 patients using a questionnaire at 2 years, and most of them said that autologous reconstruction was far more satisfactory than the implant based in terms of psychosocial well-being. Next slide, please. Now, what are the consideration which we need to think about? The anatomy of the patient. Implant-based reconstruction needs an ideal candidate who has non-redundant, healthy soft tissue, and a moderate-sized breast, which is not too much of a drooping profile. And the body mass index should be a low body mass index with not too much of fat. Smoking should not be there because it is going to affect the skin flaps. And a post-mastectomy radiotherapy is if it's there, then it increases the chance of capsular contracture. Next slide, please. Yeah, now where do we put the implant? Okay, I've done the mastectomy. Where do I put the implant? Whether should I put it prepectoral or should I put it subpectoral? Now the decision it depends on the availability of whether we are able to procure an ADM, whether we are able to procure a synthetic mesh, and if we are able to procure the one, then we can definitely do a prepectoral implant. Now, if we do not have an ADM or other mesh that we can take it, then we can take an LD, put take the pectoralis major, divide it in the medial part, raise it, and then put an LD underneath and do a subpectoral implant. Next slide, please. Now, these are the advantages. It's just the prepectoral implant just eliminates the muscle animation, the implant where it lowers the immediate pain, that preserves the muscle function. So you need not raise the pectoralis major muscle. And the drawback is just it's an elevated visibility of implant edges, higher rates of skin wrinkling and rippling effect. When it comes to subpectoral, again, it needs an added tissue coverage. It actually helps in lowering the infection because there is a cover around the implant. But if you put a implant behind the muscle, it can cause a risk of animation and muscle tightness, and it can cause an increased muscular pain because of the mobilization of the muscle. Next slide, please. Now, biological mesh which is used is an ADM or a synthetic mesh. These are decellularized meshes which we use it to cover the implant. Next slide. Yeah. Now, how do we place an implant in a patient where we are doing an NSM, or what are the things that we need to look into? It's the biodimensional planning. The surgeons tries to look the width of the breast, the elevation or the projection of the breast, the height of the breast, and then take these dimension. And there are implant size charts where we fit into the particular place, and then utilize the or choose the implant size. And then there are intraoperative sizers. So you can try it with a sizer which you can fit in into and choose the volume of implant that you want to do it. So I use a plastic cover, put a 200 ml or a 200 ml of saline intraop, and then see if that is adequate, and add the volume of saline needed, and choose the implant size if at all, if I'm in any sort of confusion. Next tab. And if needed, we can give a top up with a fat grafting. Next slide, please. Now, for an autologous, press the tabbing. Yeah, the donor site availability, it should have a good pannus or an abdominal pannus or an LD, which can be pinched nice, which can give a bulk for the breast, for a whole breast reconstruction. All these things needs to be looked into, which can match the desired breast volume. Next tab. Now the vascular health, if the patient, whenever we are doing a free flap, it needs to be a microvascular surgery, and the blood vessels needs to be healthier. If they are having a PVD or an uncontrolled diabetes, that is likely to be a patient who is going to have some prolonged hospital stay with a morbidity. Next step. And smoking is always a no-no when we are considering a microvascular surgery. Next. Yeah, these are the benefits and advantages of free flap, and the disadvantages. Again, it is a flap which is coming from somewhere else, and the anastomosis is being taken from the anastomosis is done at the recipient area and divided from the donor area. The drawback is it's a complex, long operative surgery. And the pedicle flaps are technically simpler, does not require microvascular stitching. It has a reliable blood flow, and it the problem with that is it has a limited reach. An LD can go into the outer part, upper outer part, lower outer part, but going it into the lower inner part becomes a little tedious when we are trying to plan a LD. Next slide. Yeah, these are the few cases where we have done an autologous and an implant. This is an autologous where we did a mastectomy because of her extensive DCI. She had a lumpectomy elsewhere. There was other few areas of calcification which needed excision. We did counsel her for a BCS initially, and which was later on got converted into a mastectomy on table because of persistent positive margins. Next slide. And we did a boomerang LD. This is her 2 weeks post-op picture. It is showing a good ptotic appearance. I would like to wait for another 2 to 3 months to see how exactly it actually models itself into the shape of a breast. Next slide, please. Now, this is a patient where, with a lot of thought and discussion, we went ahead with an implant-based reconstruction. This is a T4B disease which underwent a skin-sparing mastectomy. Next slide. She did not respond so well that we had expected, but she was extremely keen on having a reconstruction done. So we did a LD, extended LD with an implant, and we have gone a little bigger because we know that the LD is going to shrink and the radiation would take the LD size and the breast size down. So we've gone a little bigger on her to see if we can try and match the opposite breast. Next slide, please. Now, this was the patient who had a ulcerative lesion, again a T4B disease. Very went around with a lot of discussion. MDT is done. So we did do consider her for a mastectomy, but this time she was extremely keen, wanted to have something. But she said no doing no, not touching the opposite side. So we went ahead with a unilateral procedure. Did a boomerang LD. Next slide, please. Yeah, this is the boomerang LD where one limb is deepithelialized, the other limb is kept to fill the skin defect. Next slide. And the flap is folded on itself. And this is the final result that we could get it out of her, out of the flap, which has given a good projection and a bulk for the remaining amount of the skin and the defect. Next slide, please. Now, the new kid in the block is the robotic and endoscopic. We know that everyone is excited to do a robotic and an endoscopic nipple sparing. But I still feel that there's a long way for a robotic and endoscopic to prove itself. Is it really needed? What we could do it in 7 centimeter from an inframammary crease. Amar sir does it in what, 20-25 minutes mastectomy, and we take about 2.5 hours. Probably still we have to think whether it is really worth. But yes, there are certain areas where we cannot reach, like the upper inner quadrant when we are doing an IMF approach. So that is where the robot or the endoscopic actually helps us in achieving. So this is one of the cases that we tried. We've done about 6 cases. We're still learning. We are still in that learning curve to understand how we can improvise or grow on this. Next slide, please. Now the benefits is boost confidence and self-esteem, can restore proportionality and balance, can reduce social anxiety, improve fitting of clothes, negates the need for prosthesis, restores, this is very, very important, restores a sense of femininity, attractiveness, and more importantly, confidence in any situation. I wouldn't say only intimate situation, but potentially improving overall satisfaction and well-being. Next slide, please. So sadly, only 7 out of 10 women, 7 out of 10 women don't know that they have a right to reconstructive breast surgery post mastectomy. I think we should improvise on that and be make them more aware that there is an option that they can opt for a well-being. Next slide. Thank you so much. I'm happy to take any questions. Thank you so much, madam.
Thank you, Dr. Dilip, for such an excellent and comprehensive talk. I would now like to invite Dr. Vaishali Zamre, ma'am, for giving her inputs regarding today's topics and vote of thanks. Over to you, ma'am.
Yeah. Uh, I'm actually nobody to give inputs because this was such an excellent session with all the four faculty members covering the entire surgical management of breast primary in such a comprehensive way. So, before I actually say my vote of thanks, I would actually look into two questions. I'm sure they have been covered in the talks, but Dr. Geeta, there is a question for you. What is the adequate margin for DCIS, IDC, and malignant phylloids? So, if you could take it maybe briefly.
So IDC, it's pretty straightforward. It is no ink on tumor is for IDC. For DCIS, we still follow the 2 mm dictum. And for malignant phylloids, 1 centimeter. So borderline, they say 5 mm. Benign phylloids is anything, you know. Yeah. So malignant is
Dr. Vedant, Dr. Sidhu, Dr. Dilip, I'm sure you pretty much agree with that.
Yeah.
So there's, yeah. So there's one more question I probably didn't understand, but the person, that's Dr. Manvi Pankaj, she wants to know when post-op histopathology says that there is invasive carcinoma and DCIS component, does it mean that we haven't operated upon the DCIS and it could lead to progression to multifocal invasive carcinoma?
She
So,
probably means to ask that DCIS is there, and we have, because it is likely to be multicentric, we have left behind something. So I think it's more to do with preoperative imaging, and if imaging showed what we have removed, I think we should be fine with it.
And
yeah.
whenever there is DCIS with invasive cancer, the rule is it is no tumor on the ink margin. That is adequate. You don't have to get a 2 because the invasive overrides the presence of DCIS.
no, but if you, so pathologists will normally report on both the margin from the invasive component and the DCIS.
DCIS,
Yeah, but
correct.
if there is a combination of DCIS and invasive, then the margin which is usually recommended as per guidelines is for the invasive.
No, but
Invasive
you have to
overrides the
comment
presence of
separately.
DCIS. There should
You
be
have
no tumor on the ink margin.
No, for if you have to comment different separately, because you could have DCIs beyond the extent of the invasive also. So
Yeah.
in that case, you would want to
Yeah,
know where
even,
is the
even
DCI
suppose
stopping.
there is DCIS beyond, then it has to be no tumor on the ink margin. It need
No,
not be 2 from the ink margin.
no,
Yeah, yes,
I,
that is what the literature says.
no. For
Because recently
DCIs,
I had a
it is
patient.
still 2 mm. I don't know if there is something new that I don't know, but the dictum
Yeah,
will
because
be.
whenever there is an invasive and DCIS, the invasive cancer rules the margin status.
So, so we could have something like DCIs within the realms of the invasive, wherein, if it is more than 25%, we would even go on to say that it is extensive. That is within the confines of the invasive. But if it is outside the confines of the invasive, then you have to separately talk about what is the DCI's
DCI,
extent. We
yeah.
often see, yeah.
Correct.
So I would think it is that way. I stand to be corrected.
So let us all review what the current literature says. And with that, I would actually thank all the faculty members, Dr. Sinu, Dr. Geeta, Dr. Vedanta, and Dr. Dilip for taking us through the entire, spectrum of management, surgical management of breast primary in such an extensive and comprehensive manner. I'm sure the way you all talked about, it was very necessary for the basic understanding for the budding surgeons. I would also like to thank ABSI, Dr. DG Vijay sir, Dr. Rohit for joining hands with us and helping us, taking the reach of FSIBC webinars to a large extent. I would like to thank Dr. Arun Goel sir, Dr. Rajiv Agarwal sir for always guiding us and helping us how to, organize these webinars. Dr. Prekshi and Dr. Safalta, they work with me in, taking this FSIBC webinar series going on. I would like to thank mighty duo, the entire team for helping us conduct these webinars without any technical glitch, and taking the reach of FSIBC through their mailers and communication to a large extent. And last but not the least, the audience. Till the end, I was told that there were 90 people in the audience. So thank you so much, all of you, for motivating us and inspiring us to continue. With this, I would say good night to all of you. And our next webinar will be on the management of axilla. Dr. Sinu has already spoken a little bit about it, introduced the way we are actually thinking about management of axilla in today's times. But we will have in detail about how to manage in each and every situation when it comes to the axillary management. So stay tuned with us. We will be with you again in mid-August. So once again, thank you, all of you, and a very good night. Thank you.
All of us is also correct.